Okay, let's go ahead and get started. Welcome so much. Thank you for being here. My name is Scott Suko, and I'm the Executive Director for the Liver Coalition of San Diego. And we are excited to be the convener of today's conversation, today's learning exchange. The Eliminate Hepatitis C San Diego County Initiative is a public-private partnership to eliminate hepatitis C by 2030. The process started in November of 2018 when it was approved by the San Diego County Board of Supervisors, with the board asking us, the community, to come back with a plan of action to eliminate hepatitis C in San Diego County by 2030. A plan was approved by the Board of Supervisors in March of 2020. The implementation plan for these recommendations was then brought back and approved again with detailed strategies and tactics on July 13th of 2021. On January 1st of 2022, the County of San Diego contracted with the Liver Coalition of San Diego to serve as the convener. In addition to the County of San Diego, additional funding to support these initiatives is offered through the Liver Coalition of San Diego by AbbVie and Gilead Sciences. Today's learning exchange is HCV and Children, Setting a Roadmap for California. And it's my pleasure to introduce our moderator, who will introduce our panelists, Rick JAENISCH. A lot of people know Rick is Rick Nash. He's a patient advocate and also a director of education outreach for Optum Biopharma. So with that, I introduce Rick.
Thank you very much, Scott. And thank you again to the Liver Coalition for putting together this great learning exchange for everyone. Let's introduce our first panel. So we're just going to be the structure for this is going to be I'm going to introduce everyone, then we're going to go into the situation that's going on with hepatitis C in children, and then we're going to kind of talk about the problem more broadly, and then we're going to have a Q&A afterward. So just to go over the structure. So first, I'd like to introduce ANDREA TOMADA. And if you could just say about a minute of yourself.
Hi. Yeah, of course. Thank you so much. My name is ANDREA TOMADA. I work here at the HIV, STD, and Hepatitis branch. I'm a health program and planning specialist, and I also work as vice chair for the hepatitis C elimination effort, as well as for STI programs. And I'll go ahead and return it over to Rick. Thank you.
Awesome. Thank you. Dr. KATHLEEN SCHWARZ.
Good morning. Thank you very much for the opportunity to speak today. I am a associate physician diplomat at Rady Children's UCSD. I spent most of my career at Johns Hopkins. I've been in the pediatric liver centers in both places, and I have worked on the problem of children with hepatitis C almost since the very beginning of the discovery of the virus.
Thank you. Dr. Philip Rosenthal.
Hi, everyone. I'm Phil Rosenthal. I'm a pediatric hepatologist at the University of California, San Francisco. I, like Kathy, have been involved with Hep C from the beginning, especially in children. We were both part of an NIH study looking at HCV in children and have worked in helping to develop and get approval for the direct-acting antivirals that have now made a cure for children with hepatitis C. So I'm very pleased to be involved in this discussion today.
Glad to have you. Dr. CHUAN-HAO Lin.
I'm a pediatric hepatology at the Children's Hospital, Los Angeles. And like Dr. Rosenthal and Dr. Schwartz, I have been involved in the pediatric hepatitis C trial in couple DA medications. And in the past 4 or 5 years, we witnessed those DA medication very effectively eliminate the hepatitis C, and there's no recurrence. So I'm very happy to participate in this, process regarding the, eradicate the hepatitis C.
Excellent, thank you. And last but not least, Rachel GRINSTEIN.
Yeah, thank you. Hi, I'm Rachel GRINSTEIN. I'm the viral hepatitis coordinator in San Francisco Department of Public Health with the Community Health Equity and Promotion branch. So I mainly work on the community side of things. And I also have experience working as a Hep C navigator in the community at syringe access programs. So I definitely do not have as many years of experiences as most of the others on the panel, but I'm very happy to be here and to join it.
Great to have you. And so these are all of our panelists and myself as the moderator. I am Rick JAENISCH. I myself was a vertical transmission of hepatitis C, cured via the second generation DAAs that we're going to talk a little bit more about. And also, unfortunately, went through end-stage liver disease and received a transplant, but thankfully received a transplant in 2016 and was saved. So we're going to talk a little bit about this, about the problem here. So I'll be turning it over to Dr. Kathleen Schwartz to kind of go into a bit more about the challenge of what we're seeing here and what where the roadmap starts.
And actually, this gives me the opportunity to introduce my younger colleague, pediatric gastroenterologist Laura Baumann, who has been working with me on a project to eliminate hepatitis C, first in San Diego, and hopefully we will be able to expand it to the state and the nation and the world. So Laura, thank you very much, and let you take it away.
All right. Sorry, let me just get this. Share my screen. Okay, can you guys see my slides?
Yes.
Let's see, I usually like to do presentation mode, but there we go. Okay, so I'd like to thank the Liver Coalition of San Diego for putting together this learning exchange and for inviting Dr. Schwartz and I to speak today. And we're going to be talking about the roadmap for California for hepatitis C in children. And we know that hepatitis C prevalence in the world is rising, and an estimated 72 million adults are infected with hepatitis C. And children are also affected by hepatitis C. And hepatitis C infection is a serious global issue. It's one of the most common causes of chronic liver disease worldwide. It's a leading cause of liver transplantation in adults and a leading cause of liver cancer in adults. So how do children get infected? Vertical transmission during childbirth is the most common form of transmission, but a second way is via injection drug use, which we all know is increasing dramatically even among adolescents. But most children who are at risk for hepatitis C are never screened, diagnosed, or treated. And we also know that hepatitis C cases are rising in women of childbearing age. Here you see the cases per 100,000 population. And I've highlighted those between the ages of 20 and 39, which is kind of traditional childbearing ages. And those have steeply increased. And vertical transmission is an ideal time for prevention. Because if we can prevent the disease, in young childhood or just childhood in general, then we can prevent horizontal transmission and further vertical transmission. And there are known risk factors for vertical transmission of hepatitis C. So, the obvious one would be hepatitis C viremia in the mom, or HIV co-infection, or any maternal IV drug use. Possible risk factors for transmission include invasive prenatal testing, prolonged rupture of membranes, or obstetric procedures. But those factors that are not associated with transmission would be mode of delivery, so whether it's a vaginal or a C-section delivery, and breastfeeding. But we can't treat pregnant women yet, although there is on the horizon, a therapy that is thought to be safe in pregnancy. So hopefully that will be an option in the future. But what about testing and treating newborns? So as pediatricians, we always like to say that children are not little adults, and that is true in the case of testing for hepatitis C in a newborn. Historically, the American Academy of Pediatrics states that we cannot reliably test exposed children with the antibody test until 18 months of age. And so, this is a complicated graph, but essentially you have to wait until the mother's antibody has gotten out of the baby's system enough and the infant's antibody has taken over before you can accurately test. However, the CDC did make new recommendations based on improved PCR-based testing. So that's the nucleic acid test. So perinatally exposed infants can now be tested between 2 and 17 months with that PCR test. And then those that are 18 months or older can be screened the routine way with the antibody. But again, we can't really test the infant right at birth. And now I'm going to turn it over to Kathy for some personal history.
Thank you. So last spring, I attended a Scripps Institute conference on adult liver disease, and I heard John McHutchison make a very nice presentation about the Netflix model for eradication of hepatitis C in Australia. And he talked about he used the slide that Laura showed earlier, 72 million adults in the world with hepatitis C. John is an old friend, so I asked the question, John, what about the 3.4 million children in the world with hepatitis C? What are we going to do about them? And I'm passionate about this question because like Dr. Rosenthal, I have spent over 3 decades of my own experience in kids with hepatitis C. So the molecular structure of the virus was described in 1989, and soon thereafter, my boss at Johns Hopkins, where I was director of Pediatric Gastroenterology, called me in his office and said, Kathy, you have to do something about this hepatitis C. He's a pediatric hematologist and he cares for a large number of children with hemophilia and sickle cell disease. And at that point, many such people who were receiving multiple blood transfusions were dying of hepatitis C during adulthood. So he said, do something about it. So I started, and one of the things that I did was to do a study funded by the National Institute of Health in historic East Baltimore, working in homeless shelters. And we learned that 20% of the homeless caregivers in Baltimore were hepatitis C positive. And so then we just became very concerned with the enormity of this problem and embarked on several multi-center trials, the largest of which was called the PED-C trial, and Phil Rosenthal and I were involved in that. And it was a randomized controlled trial for children with hepatitis C. And it was as a result of those experiences, I probably have cared for maybe 200 children with hepatitis C. And it's such a tragic illness because many of these children had lost their mother of hepatitis C or hepatitis C and HIV co-infection. And although the majority of them look well, they all suffer from stigma and from fear of cancer and cirrhosis and liver transplant and death during adulthood. We did even write up 2 children that had liver cancer from hepatitis C. But this one child named Brian was the absolute saddest hepatitis C story. And I've practiced pediatric hepatology for more than 40 years, and it has remained one of the saddest stories. Can you advance, Laura? So here's Brian's tragic story. His mother had bipolar disease, And she acquired hepatitis C during injection drug use when she was 14 years. And then when she was 40, Brian was born. And he actually had been cared for by another gastroenterologist. He came to me looking like this, the middle picture, looking like an old man with cirrhosis. He was jaundiced, he had ascites, he had end-stage liver disease. And so there was a lot of discussion. We were one of the first institutions to do living donor liver transplant. And the mother, who had no clinical liver disease, felt very, very guilty about giving the virus to the child. So after a lot of review with ethicists and transplant center experts, we decided to do a living donor liver transplant. We did it when he was 5. He had vicious recurrence of hepatitis C, as often was the case when we tried to do liver transplant before we had these wonderful new drugs. And the child died of recurrent hepatitis C after the 3rd transplant at age 8. So this is my most powerful motivation to try to do something about the problem, the very enormous problem of children with hepatitis C. Thank you, Laura.
Thanks, Dr. SCHWARZ. So we know that affected infants in the US are sharply rising. And this is the mean number of US live births that are affected by hepatitis C due to vertical or perinatal transmission. And you can see it's going up. And many exposed infants never have follow-up testing. And this is a paper in Pediatrics. It's one of our big journals in 2020, showing that 75% of exposed infants in Tennessee were never tested for hepatitis C. But we do know from other research that routine screening of hepatitis C in adolescents and young adults is cost-effective. And as we all know, the hepatitis C therapy is now much more effective. So you can see the cure rate increasing dramatically from in the 90s when we only had interferon. And then it became, pegylated interferon with ribavirin. But as the direct-acting antiviral agents came on the market, that really changed the landscape, especially with the 2nd and 3rd generation of those drugs, that the cure rate is now so great with the therapy. So we know that drugs can now cure hepatitis C in children, and these drugs are oral. They are only a 2 to 3 month course. They're approved for ages 3 and older. They even taste good, and they're safe. So our team goal, or the goal that we've been talking about a lot, Dr. SCHWARZ and I, is to develop a scalable intervention that we might be able to start in San Diego and then move it to all of California, to the US, and then hopefully worldwide. And we think that some of our high priority goals should be to screen high risk children and then link them to appropriate care. So some of the high risk children that we have that we've thought of would be obviously children of hepatitis C positive mothers and children of IV drug users. But other children that we might be missing would be immigrants from high prevalence countries, foster children who often have high ACEs, and ACE is an adverse childhood event. And so these children are often exposed to more difficult situations, drug abuse, things like that. And they have a higher risk of depression and substance abuse as they get older. And then international adoptees. But we will have some challenges ahead of us. The USPSTF did not recommend routine hepatitis C screening in children. And so we still have to develop a plan for reimbursement for testing and for treatment. And then, how best to identify and screen the high-risk children, and what, if any, policies could be put in place to help streamline that goal. So this is our call to action. How can we cost effectively screen California's children for hepatitis C and link them to appropriate care? Thank you. So my kids.
Thank you very much, Laura.
Very cute. All right. Well, that was excellent. Thank you very much for laying out the roadmap here so we can really start to kind of, now that we know where we have an idea where we're going, we have an idea where we're moving, we have an idea what's happening now with the challenge of hepatitis C in children. I know myself, I was when I was diagnosed in 1999, there were no such options. So seeing how these options have expanded over the years has been something that's been nothing short of monumental, let alone the tasks we are now undertaking of actually instituting systems to help make sure to turn this from treatment into prevention, as treatment as prevention. So maybe we should kind of start with, advancing from that last question there and say, what needs to be done by systems, local, state, and federal government to keep us on track for this type of hepatitis C elimination. Since we're largely focusing generally on hepatitis C elimination here in children, this presents a micro elimination opportunity. So again, what needs to be done by systems, local, state, and federal government to keep us on track for HCV elimination, and we can focus it on children? I'm going to open the floor to anyone who would like to answer the question first.
Well, I think we have to figure out how to pay for the screening of these high-risk children, because it seems to be not so easy. So one thing is getting coverage for screening, and the other is trying to figure out how to access these high-risk groups. For example, foster children, adopted children, we have started to do that in San Diego, but it seems that it's not so easy to identify these children.
Or identifying, where and getting that initial testing. Obviously, we have some kind of guidance, I guess, from the CDC coming in saying that we now are having better criteria, I guess, more clear criteria as to when we do the testing there. But what other elements might we see? So obviously the repayment schemes are a component that's very necessary to have very, very solid, makes sense. Are there any other areas that we can think of that might also be essential here for systems?
Hi, this is Andrea Tomada. I just wanted to point out that in the chat, I included CDPH's recommendations for screening for newly arrived refugees, asylum seekers, asylees, and humanitarian parolees and populations in California. And essentially, these are the recommendations that children 18 and under do get tested for HCV. So one of the things we could look at potentially in the future is we currently have our own refugee health here in San Diego County, and we could have that discussion as to, is this currently happening? And if not, what are ways that we can do to ensure that these recommendations are in place?
Well, Andrea, that would be great. I can tell you that Dr. Janine Young, who I think is not able to be in on this particular conference, is the new chair of academic pediatrics at UCSD. And she comes from the University of Colorado, and she is very interested in the problem of viral hepatitis in immigrants, including refugees. And she has just started to work at the family health centers of San Diego, where I think there are a large number of such children. And she found that the testing was not being done certainly not being done in a systematic fashion. So maybe we can since she just is in the family health centers, maybe we can get together with you and her and try to figure out how to make things better. I will also say that in those family health centers, Dr. Jeannie Wang and I did succeed in integrating a reminder to providers to screen for hepatitis B based on the country of origin high prevalence. So there were many immigrant families who were from countries where there was a hepatitis B prevalence of 2 to 8%. And linking that reminder to the providers did, in fact, result in many more people being identified as hepatitis B positive, and we published our results, and we were able to do this even during COVID. It's Jeannie who gets all the credit, but Laura and I have been thinking we could do something similar to link reminders to the providers to screen people from countries with a high prevalence of hepatitis C. But maybe according to what you just provided, maybe there's more universal screening endorsement. It's great. We just have to figure out how to get it done.
Hi, Andrea. This is Pristy Quijada, Refugee Health Coordinator for the County of San Diego. I just wanted to add a few things. Yes, as part of our Refugee Health Assessment Program, we do screen for hepatitis. And there's challenges in that although all refugees are eligible, we don't see all refugees because they have to be referred to the program. And there's agencies that for whatever reasons, cannot or won't refer to us. And that poses a challenge because we're not able to capture the 100% of the newly arriving refugees. Some are also, they either move to other states, which also makes it challenging. But I'm happy to have a further discussion to see how we can improve this as part of RAP.
Great.
It's phenomenal. I love how this is going organically like that.
Yeah, I was going to mention that I think it would also be useful to get both pediatricians and family docs on board because, primary care is probably the place where most of these children are being seen. And if you could somehow reach out to get them involved, that would probably be helpful in finding the patients and then getting them screened, because it's one thing to screen them, it's another to find them.
I agree completely. Can you tell us more about the situation in San Francisco, Phil?
Well, I get a lot of referrals from all over the state, actually, from primary care docs and pediatricians and nurse practitioners these days. So that's where most of the referrals are coming from. I saw that there was someone on this call that is involved with San Francisco, so I definitely would love to hear about what public health initiatives are being done as far as the kids go. But I definitely see all the time kids that are referred to me, so somebody is doing a good job of screening them. I know on the adult side, Jen Price, I believe, has a whole van that goes out and screens adults in neighborhoods for Hep C.
So can you share with us?
Side, I'm not aware of anything like that.
Are the children that you're seeing with hepatitis C, are they international adoptees, immigrants?
No, they're mostly
Franciscans.
Yeah, they're mostly maternal patients, and that's what I was going to also comment. It's one thing to talk about patients that are coming in as immigrants, but there's also a whole group of patients, depending upon where in California, that have large pockets of Hep C in the population, and they're not immigrants. They're like in Northern California, for example, there's certain areas where there was a lot of drug use. And a lot of the moms have been treated, and those moms are actually some of the ones that are most interested in having their child tested and treated. The other group, I would say, are kids that are adopted or in foster care that
Yes.
were taken away from their mothers. And that's another big group of kids that I've been treating that I see.
Yes, and I would say my experience, and I've only been in San Diego practicing since 2018. First of all, I haven't seen very many children with hepatitis C, not nearly as many as I saw in Baltimore. And the few that I have seen are either immigrants or foster children. So it's quite puzzling to me, because I know that the adult hepatitis C screening programs are quite active. So, and we are, I think, one of the few places where children are treated with hepatitis C. So it's just, I think we need to do a better job.
Yeah, well, I agree. I think
Yeah.
they're there. There's no doubt in my mind. I don't think Southern California is much different as far as drug use and those type of issues. And
No,
I
don't
gotta
think so
believe,
either.
right? I gotta believe that if you can get into, you know, the nurse practitioners and the family docs and the pediatricians that are caring for those kids, that's gonna go a long way in helping to localize those patients and get them screened and treated if necessary.
Yeah, absolutely. And I think that as we talk more about the screening elements as well, I think it might be good to ask our one of our panelists here, Rachel, who also kind of does. Actually, I'll let you explain some of the work you do, because you do great work up there in San Francisco.
Yeah, thank you. Yeah, I think so we focused mostly on perinatal Hep C rather than in children recently, at least like within the health department. And we had a review and kind of assessment of our perinatal Hep C a few years ago, and the prevalence rate, it was estimated at 17 infants being born within that year. I believe it was looking at either 2020 or 2021. And we hadn't identified any. So I think there the gap really, you know, is in getting the right infants and children tested, rather than doing kind of larger scale test screening. And I think, you know, to Dr. Rosenthal's point, you know, I think especially in San Francisco, what we've focused on and where the you know, kind of the movement has really focused on is within high risk perinatal care and high risk pregnancies. You know, and we've talked a lot with like the like Team Lily, which is a group that works with HIV positive pregnant people, and also, or I'm sorry, Team the Hive is that one, and Team Lily works with people experiencing homelessness who are pregnant. So, you know, I think that a lot of the efforts that we've been looking at are on that end of it, and really working with the birth parent during pregnancy, ideally, because that, you know, there's a lot more interaction there, hopefully, and also after birth, and then, you know, as you mentioned, you know, I think that also working with foster programs and you know, and adoptive systems and working with guardians is really important there as well, because obviously with that, the guardian may not know that their child is at risk and needs to be screened or should be screened. And I think that that's more on the end where the health department can step in and can provide you know, notification to both to the pediatrician and to the birth parent. And, you know, obviously, you know, if there's permission to share that information with the guardian, then they could.
Yeah.
Well, that would be great. I was struck last fall when at AASLD, I attended a day's conference on perinatal HCV. And the speakers were from injection drug use clinics around the country, and they were passionate and effective about screening the mothers. But it really struck me that even though these were the experts in the country who really were doing a wonderful job of screening their patients, none of them had follow-up data on the infants. So the one that was the most active had follow-up data up until a year. And as Laura said, the FDA-approved treatments are not approved under age 3. And there's a good reason for that, which is half of the babies who do acquire hepatitis C from their mothers actually spontaneously clear the virus, so they don't need to be treated. But I think that, the huge gap remains between the obstetricians on the one hand and the pediatricians like us, the 4 of us who take care of children with hepatitis C. We need to close that link. And we also, Bill and I have been involved with a project to try to expand knowledge about hepatitis C to family practitioners, nurse practitioners. So it used to be that people who treated children with hepatitis C were generally liver doctors, of which there are only a few oddballs in the country, right, Bill? But really, you don't need to be an expert in liver disease, and you don't have to be able to do a liver biopsy. We don't recommend that anymore. So it's a matter of working with public health officials to link the detection of hepatitis C in the newborn to people who can care for the children when they're 3, so they don't have to suffer the story that I shared.
Yes, that was a very touching story as well. As a person who received hepatitis C through vertical transmission, and I was diagnosed at age 12 from a liver biopsy. So I appreciate that now we have much less invasive procedures and much and early onset and early on therapy. So therapy that's curative, that can be short, that it could taste good, I guess. Because I can imagine as a child.
I mean, it's just a sugar syrup.
Yeah.
Yeah.
And it's phenomenal progress. I mean, it makes almost always, as Laura said, almost always makes the virus go away.
Yeah, 84 to 96%, depending upon the particulars. Myself, I was in an unusual scenario, but I was on the interferon ribavirin before then, and then was eventually cured on my 6th treatment in 2017 after my liver transplant. So these things can happen, and end-stage liver disease can take years out of your life. In my case, it took about 7 years out of my life, and I'm lucky because I'm still here alive and with you guys today. But as we're talking, I'm seeing that this kind of care continuum, the continuum of care, there are some missteps, there are some opportunities and barriers. So what does the continuum of care look like for patients with HCV who've contracted via vertical transmission? So saying kind of the mother, but predominantly focused on the child. Are there any, I think we've talked about, in a general sense about opportunities and barriers, but are there any opportunities and barriers that you find most obvious that maybe we can kind of approach today?
Yeah, I just wanted to comment that the other group that we didn't mention is infectious disease experts, because I've often got referrals from ID docs, mainly because they don't feel comfortable or don't want to take the time to treat Hep C. And like we mentioned, you don't have to be a specialist anymore to write a prescription for a direct-acting antiviral, but you do need to understand what you're doing.
Yeah.
And I think, most pediatricians, nurse practitioners, family docs don't have that expertise, but I think that many ID docs do. and it would be wise to include them in this initiative. And I don't know if there's any ID docs on this call, but I think that would be an important thing to do.
And maybe we can hear from Dr. Lin about what happens in Los Angeles, if he's still on. Maybe not.
I don't know if you're willing to take a perspective from the other side of the country. Dr. Schwartz, this is Lori Williams. We met at that meeting at AASLD.
Yes.
You know, I'll just say that where I am on the East Coast, there's a lot of MAT that's part of family practice. And when we're talking to MAT providers, we talk to them a lot about not only talking about hepatitis C screening for women who are currently pregnant, people who are currently pregnant, but for people who have children at home, and to find a sensitive way of saying, do you have children at home? If so, they should be screened for hepatitis C. And when it's perfect, and that child is also getting their care in that family practice setting, the provider can just screen the child when the child comes in. The problem then becomes that that provider can't treat, because currently there's nothing from NASPGHAN that says primary care folks can treat in the same way that it's explicitly said by AASLD with the simplified treatment algorithm. So, you know, it's interesting to hear how different things are for you where you are, but this is certainly a little bit of a different story on our side of the Mississippi.
Well, it's interesting that you mentioned NASPGHAN, because we actually have developed a teaching slide set that's freely available, and it covers all aspects of hepatitis C. And then we made a simplified, I think there were 120 slides in that set. And then we made a simplified version with the American Academy of Pediatrics that we thought would be, you know, very practical and easily used. And NASPGHAN, it's interesting. I don't think of NASPGHAN as a policy-making individual. I have been president of the society. It covers about 95% of the 2,000 plus pediatric gastroenterologists in the country. But maybe we should revisit that. What do you think, Phil? Phil's also been very active in NASPGHAN.
Yeah, absolutely. I don't see any reason not to. Obviously, you and I are no longer part of the Hepatology Committee, but
right.
we know the right people.
We can raise our hands and make suggestions.
Right. We know the right people to
yes, we do.
influence.
And let's see, now that I see Dr. Lin on the phone, let's hear how things are in Los Angeles. What are the difficulties you see in identifying children and treating them?
Yeah, thank you. So I think I share the same kind of situation with Dr. Rosenthal. I think in Los Angeles, we have the same, pretty much the same. We get some referral from, you know, outside pediatricians, but not a lot. I think the my kind of impression is we definitely need to get more public health department personnel or kind of organization help, because we know there's quite a bit. There's the panel mentioned about the immigration populations, you know, the mother that have history of hepatitis C. There's a lot of potential. We need to screening and to identify the patient and get treated. But I don't see, at least in Los Angeles, I don't see much effort at all. And I'm very happy to see San Diego and San Francisco have much better kind of, you know, activity going on.
No, actually, I would say the opposite. LA actually just last year they started doing case investigation and notification for perinatal Hep C. And San Francisco, we haven't started it yet. We're still in the planning stages and have been, you know, having a lot of strategic discussions, and we have a task force, and we're doing, you know, kind of like small movements and incremental work toward that, but we're not actually doing case investigation and notification. And LA is, they're actually, when one of the stages of our planning, we talked to a few jurisdictions that have perinatal Hep C programs that we wanted to get advice from. And so LA and Philly were the two cities that we talked to that, you know, are kind of, Philly is the most well-established and has a really impressive perinatal Hep C program within their surveillance program, and for case investigation and notification. But yeah, LA is further ahead than San Francisco. I can't take credit.
So
Okay,
Rachel,
thank you.
how does Philadelphia do what you say? I mean, what's the secret to their success?
Well, they have really amazing people, for one. So, you know, their surveillance program is really impressive. And it's very small. You know, like New York City also has a very impressive surveillance program. That's also because that there's really amazing people on it, but they're also much more well-funded and well-staffed. Whereas Philly is, I mean, they're not very big. It's, you know, 3 or 4 people. But they do really amazing work. And so their perinatal program has been around since 2014. So partly it's that they have had negative RNA labs were mandated to be reported to them earlier. Whereas like in California, we've only just this past year been able to actually get negative RNAs from like 95% of the labs to share them. So they had better data. And then they also, you know, they have a person who basically runs a match between their Hep C registry and their vital records for births. And then they have a very well-established program and method of you know, like contacting the birth parent and the provider or the pediatrician kind of at the same time. That was one of the like sticking points, I think, that was a bit tricky, is obviously because that so often, first of all, patient information, contact information often is no good and it's hard to reach people. And also often the birth parent isn't, the child isn't in the birth parent's care. So I think LA and Philly have kind of went about it a little bit differently. LA's approach, I believe, is contacting the provider first, and also attempting to contact the birth parent. And I believe Philly, they contact the two of them at the same time, like they try simultaneously to connect on both ends. You know, but they, you know, in both programs, they track them for 3 years. So, you know, after 3 years, they follow up to see if, you know, if they've been received treatment, if they were positive. Obviously LA hasn't quite gotten to that point yet. But yeah, I mean, it's an impressive program, but even with Philly being so well established, there's still a lot of difficulties and a lot of complications and hangups with it. And it's not something that's as straightforward as it seems like it should be.
Right.
Definitely a lot of moving parts with this, certainly. Before we go to our last question here, I just wanted to see if we have any questions from our audience. We have a lot of folks from around the country here today. We've had a few folks interject, and it's been fantastic. Thank you again for that organic interaction. We greatly appreciate it. You know, even here as a panel, it's great to hear from folks around the country who are all trying for the same success. So if we have any questions, please feel free to use the raise hand option, and we will draw on you from there. And if I don't see any hands in the next minute, I'm just going to move on to our next question.
And Rick, I know that Andrea has been monitoring the chat, so if I could call on her and then also
Certainly.
her to share what San Diego is doing.
Yeah, absolutely.
I just wanted to add that there is a question in the chat from Rachel McLean. Her question is, any research on post-exposure prophylaxis at birth that would certainly make it easier is what she's saying. Any comments or thoughts on that? And then I can share how San Diego's doing if we have enough time.
Well, I love that question. And I don't know of any research on the post-exposure prophylaxis at birth. And I think, as I say, one of the issues is that half of the children who acquire hepatitis C don't, they may lose, half of the children may lose the virus. And then the other is that because of the low level of viremia in the newborn who might get hepatitis C, that is the basis for the CDC recommendation to waiting till 2 months to screen, even with the hepatitis C RNA. So where people have been putting more energy is in treating pregnant women with hepatitis C in the 3rd trimester. And Laura showed the graph of the declining hepatitis C RNA in this one pilot study, and there is a larger ongoing trial. I don't know, Phil or Dr. Lynn or Laura, does anybody know of anything else?
I'm not aware of anything perinatal.
Yeah, I think for the same reason that it's either 3rd trimester or at age 3.
Yep.
All right. Thank you. Then Andrea, if you'd like to wrap us up with what's happening in San Diego.
Sure. Let me go ahead and share my screen here. Make sure I get the right view. Okay, is everybody seeing my screen okay? Yes, okay. All right. So for pediatric cases, mean diagnosed and reported when under age 16, what we're seeing here is we've had 7 confirmed pediatric cases. And by the way, this has been our new, we've been collecting data since 2020 and now through 2023. But we've had 7 confirmed pediatric cases. One of those cases is perinatal, having been diagnosed at less than 3 years of age. 6 were diagnosed at 3 years of age or older. 2 diagnosed at 2 years of age or older were perinatal exposure by medical record review, but diagnosed later. And then, 2 came from areas of high endemicity as refugees. And then for 2 cases, we never received medical records to be able to determine diagnosis. And then there were 4 non-residents confirmed pediatric cases in those over age 3 years. And 3 cases were found during medical record review as perinatal exposure, but diagnosed later. So this really speaks to that gap that some of these cases, let me even stop sharing my screen, that some of these cases may have been diagnosed early on or maybe even later, but not necessarily reported or that we were able to get some of that information. I also have Dr. Tweeten, our epidemiologist, on the call too. So if she'd like to add anything additional, I'd like to open the floor to her as well.
Sorry, I had a slight unmuting problem, as one does. Thank you, Andrea. Yeah, we've been actively searching for pediatric cases of any variety, and it is one of our priority populations. Most of what we've had, I think it was Rachel who was talking about the negatives that we don't get, and that's been part of the drawback that we have. I was glad. I want to say thank you very much because I am going to be talking to somebody in Philadelphia because it sounds like they've got small staffing but are doing great work, and we have teeny weeny staffing and are trying to ramp up a program. So thank you.
Well, thank you very much for the update. All right, so we're going to do this last little question here before we kind of close out. So we've covered a lot today. all along this roadmap about what we're doing all across the state, what some of the how some of these things are working across the country, what is actionable and what is achievable. What can we do with what we learned today? Then I'll open the floor to anyone on the panel.
Well, I am motivated to invite Andrea and Samantha to meet just to share our perspectives and see what indeed is actionable. So I think we're going to find that there are things that we can teach each other.
Absolutely.
It's not. Oh, go ahead, Andrea.
No, go ahead. You're good.
Okay. It sounds like that provider education is still really needed, both for treating children and just treating in general. So I know the perinatal task force in San Francisco has talked about developing a pocket guide for I believe for pediatricians and possibly also a separate one for providers for OBGYNs. So I think like more things like that, doing more provider education and kind of promoting things like the e-consult line and resources that are already available is still.
And Rachel, you might look at that NASPGHAN short slide set. We actually spent quite a bit of time on it with the American Academy of Pediatrics for exactly the purpose that you're talking about. If you can't get it, just get in touch with me and I'll get it for you.
Very good.
Thank you.
Sounds like you've got one closing thought before time.
Anyone with closing thoughts?
I just like to say thank you so much for assembling this wonderful group of people. Takes a village.
It does. Well,
Yeah.
thank you all for joining us today. This has been recorded. It will be uploaded on our YouTube channel and sent out. And let's keep working together and building this partnership. Have a great day, everyone.
Thank you so much,
Thank
Scott.
you.
Bye-bye.
Bye.
Bye.